to Ground Rounds. We have the pleasure to have today Dr. Rafael Merchant. He completed his medicine school in the Universidad Católica Santiago de Guayaquil, then he completed a master in Harvard Medical School. Then he did residency in the University of Miami-Jackson Memorial and moved for fellowship to Deaconess Medical Center and Harvard Medical School. He has been working with the University of Miami since 1997, and he's currently one associate professor of medicine. Welcome, Dr. Merchant. Welcome, everybody.
Thank you very much for the introduction and the invitation. Yes, I have been at UM initially for my residency in the late 1990s before I went for fellowship, and I came back as a faculty member, as a junior faculty member in 2006. And I am a medical oncologist by training, and my areas of interest are in GU medical oncologist and also clinical and translational research. So today I'm going to talk about some of the most recent advances in the treatment of metastatic urothelial cancer and kidney cancer. Rather than give a very, very long and comprehensive review of each of the diseases, I'm going to focus on what is new and what has made a kind of like a FDA approval in order to provide new options for patients, and how have we improved the management of patients with these advanced cancers. So we're going to start with a urothelial bladder cancer first, and this is a relatively common malignancy. It is the sixth most common cancer in the US, with about 81,000 cases and almost 18,000 deaths. There are several risk factors for a bladder cancer, where the most common histology is urothelial or transitional cell carcinoma. Other less common subtypes are squamous cell or adenocarcinoma. And the most relevant risk factors for urothelial bladder cancer are tobacco, also some family history, several chemicals, history of prior radiation to the pelvis, and several chemo agents, especially cyclophosphamide and ifosfamide. Bladder cancer also is associated with long-term or chronic bladder irritation, like in patients who are paraplegic and have long-term urinary catheters, and several bladder infections like schistosoma hematobium, which is associated with squamous cell carcinoma. Most of the cases of bladder cancer are diagnosed at an early stage, like a superficial cases in about 75%. Superficial means that either has not invaded the lamina propria or that have not invaded the muscle. So those are usually the T1 tumors. Then about 10 to 15% of the cases are a little more advanced, which that means that they invade either the muscle of the bladder or the adipose tissue. Those are usually T2 and T3. And also some T4 tumors may invade other adjacent organs like the prostate or the rectum sometimes. 5% of the patients present upfront with distant metastases. And bladder cancer can metastasize anywhere, but some of the most common sites of metastases include the lymph nodes, the lungs, the liver, and also bones. The 5-year survival rates are very good in superficial disease. However, in patients with locally advanced or metastatic disease, the 5-year survival decreases significantly. This is a busy slide, and it summarizes the overall management of bladder cancer by stage. And one important message in the management of bladder cancer is that the management is always multidisciplinary. It always will involve the urologist, the medical oncologist, and sometimes the radiation oncologist as well. I'm not going to review all the treatments for the different stages. I'm going to focus mostly on the management of advanced bladder cancer. And historically, the treatment of patients whose bladder cancer has metastasized to distant organs has been chemotherapy, and mostly cisplatin-based chemotherapy. And we usually have two regimens that have proven effective in the first line with cisplatin, such as gemcitabine and cisplatin, or MVAC, which is methotrexate, vinblastine, erythromycin, and cisplatin. In patients who are not eligible to cisplatin-based regimens, for example, patients who have renal dysfunction or severe neuropathy or hearing loss, in addition to cardiac comorbidities, there's an alternative regimen that also has proven effective in the metastatic setting, which is gemcitabine and carboplatin. So this is what we had for patients and still have for patients with metastatic disease. And what we usually do is we give 4 to 6 cycles of chemotherapy with cisplatin-based or carboplatin-based, and after the 4 or 6 cycles, usually a good number of patients, about 40% of patients, have reduction in the size, and probably 20 or 30% more have stability of the disease. We stop chemo and we continue following the patients with clinical evaluations, lab, and also CT scans. And the great majority of patients, even though they may respond nicely to upfront chemo, the great majority of patients recur and die from the disease. What we used to do after patients fail first-line cisplatin or platinum-based therapies is to give second-line treatments, mostly based on taxanes or microtubule interfering agents, either alone or in combination. However, the prognosis for patients who recur or progress after platinum-based therapies is extremely poor. The progression-free survival is usually 1 or 2 months, and the majority of patients die from the disease. And we used to have those only options until about 2016, 2017, when the big explosion of immunotherapy trials came. And from 2016 on, there were 5 different immunotherapy agents approved for the second-line setting, meaning patients who have failed platinum-based regimens, right? And those studies showed that patients who were progressing had good response rates and significantly improved survival compared to either no treatment or compared to taxanes. In addition, in around 2017, 2018, atezolizumab, which is an anti-PD-L1 monoclonal antibody, and pembrolizumab, which is an anti-PD-1 monoclonal antibody, both given intravenously, were also shown to have benefit as a first-line regimen in patients who are not eligible for cisplatin. Now, in 2018, the FDA provided a clarification and further guidance to restrict the use of first-line immunotherapy, okay, in patients who are cisplatin ineligible and who have also high expression of their target, which is PD-L1 in their tumors. Okay, so this was a significant improvement in the management of patients with metastatic bladder cancer. However, there were several questions that were still unanswered and that significantly affected patients' prognosis. For example, what do we do after we complete induction chemo with platinum-based regimens for 4 and 6 cycles? Should we continue waiting until the patients recur, or can we do something to prevent recurrence and improve survival? Second, if patients progress on the second-line immunotherapy, right? So they failed chemo with platinum agents, they failed immunotherapy, what are the options? Until about 1 or 2 years ago, the options were, again, taxane-based chemotherapy if you were in the US, and vinflunin-based chemotherapy if you were in Europe. And so all of these questions were open, and they really limited us medical oncologists in terms of what can we do to help our patients. So the talk, this first part of the talk, will focus on those questions, right? So we're going to go to the first study, which is the JAVELIN Bladder 100 study, which tried to answer that first question. In patients who have a response to platinum-based chemotherapy in the first line, is it okay to just continue following as we do all the time, we have been doing, or can we give immunotherapy with avelumab, okay, to keep the response? Okay, avelumab usually has less side effects than chemo and is better tolerated. So would giving avelumab soon after finishing chemotherapy in patients who responded or have stable disease, is that better to what we're doing now? And this study was a 700 patient study, and they were randomized half and half to either avelumab 10 milligrams per kilo every 2 weeks, continuously until progressive disease or toxicity or patient withdrawal, or best supportive care alone, which is the standard treatment at that time. Primary endpoint was overall survival. And to make the long story short, this is what the primary endpoint showed. Patients who were randomized to avelumab maintenance after a platinum-based chemo had a significantly improved overall survival. Median overall survival was 21.4 months compared to 14.3 months, with a hazard ratio of 0.69, highly significant. So these incredible positive results showing that avelumab was beneficial and maintained and continued and helped keep the good response to chemotherapy led to FDA approval in June of 2020. So we are starting right now to give our patients, or to offer our patients, maintenance avelumab after chemo. And that has made a big difference in the way we now treat first-line patients. The second and third studies are answering the question as to what to do when patients fail chemo and fail immunotherapy. And the first agent that was developed was based on the finding that mutations or alterations in the fibroblast growth factor receptor 3, mostly, and also FGF receptor 2, had alterations that were responsible for disease progression. In bladder cancer, FGFR3 alterations occur in about 20% of all bladder cancers, but it is rare in advanced metastatic disease with about 10% or less. So, based on these findings, a small molecule inhibitor of FGF receptor, erdafitinib, was developed, okay, and it showed good activity in vitro, in preclinical models, and in phase 1 studies in patients who have FGF alterations, including urothelial cancer and also cholangiocarcinoma. So this was a phase 2 study, was a pivotal phase 2 study that was done after phase 1 results showed promising activity in patients with bladder cancer with FGF alterations. And this was a kind of like a precision medicine phase 2 study where all patients had to be screened for FGFR alterations, and if they were positive, they were enrolled, and they were randomized to different doses, different regimens, okay? And the regimen that showed to be associated with better tolerance was 8 milligrams every day for 2 weeks, and then depending on tolerability, they could go up to 9 milligrams. Patients were, there were about 99% of patients, okay? And the population was patients who have progressed on 1 or more lines of systemic chemo, and also prior immunotherapy was allowed. The results also were very, very promising. As this study, patients who were treated with this agent had a 40% overall response rate with a 3% complete response. And overall, about 76% of all evaluable patients had some degree of tumor reduction. This was associated with a progression-free survival of 5.5 months and an overall survival of 13.8 months. This, even though it was a phase 2, this led to accelerated FDA approval of this drug in April of 2019. Finally, for again, for advanced bladder cancer, there was a new drug that was being developed, and we at UM participated from the first in-man studies with this agent called enfortumab vedotin. Enfortumab vedotin is what we call an antibody drug conjugate. The antibody part targets Nectin-4, which is a transmembrane adhesion molecule expressed in many epithelial cancers and about 93% of patients with metastatic urothelial cancer. This antibody is conjugated to a cytotoxic agent called MMAE, which is a marine compound that acts by disrupting the microtubules of the cancer cells. And this is a very nice example of a targeted, smart targeted form of delivering chemotherapy, where the antibody finds the Nectin-4 expressing tumor cells. It is internalized, right? And then lysosomal enzymes will cleave the linker and will release the cargo, will release the MMAE into the cells and will cause apoptosis. We participated in the phase 1 portion of this study, and we saw a 41% response rate in patients who had prior been treated with chemo or even with immunotherapy. And this led to the next study, which was called the EV201 study, all right, which had 2 cohorts, and the cohort 1 was the cohort that led to FDA approval and included patients with metastatic urothelial cancer who had failed platinum-based agents and immunotherapy. So this was heavily pretreated patients. As you can see in the waterfall plot, this agent was associated with a very, very high response rate. Okay, confirmed response rate was 44%, with 12% of complete responses and 28% stable disease. So this agent was not associated with significant toxicity, except for 2 AEs, including neuropathy, which was the most common AE, and also skin toxicity, like rash, alopecia. We did not see significant myelosuppression. We see some myelosuppression, but not as significant as chemotherapy. Again, progression-free survival was 5.8 months, and median overall survival was 11.7 months. And this study also led to FDA approval of this agent in December 2019. So, toxicity, again, the most common were peripheral neuropathy and maculopapular rash. Currently, the enfortumab is being studied in the randomized phase 3 trial for patients in the 3rd line, comparing this enfortumab vedotin versus standard chemotherapy, which is mainly taxane-based therapy. Okay, so in conclusion, for the bladder cancer part, we have answers to some of those questions. Okay, so what we're doing now is the 1st line setting, patients who are getting platinum-based therapy and who have a benefit, we offer them maintenance avelumab. Now, if patients progress on maintenance avelumab, or they were on prior immunotherapies and they progress, now we have 2 very promising and effective options. Okay, a precision medicine option, which is erdafitinib in patients whose tumors express altered FGFR receptors, or enfortumab vedotin in patients who progress independent on any alteration. So the next topic, which would be much faster, will be renal cell carcinoma. This is my area of research interest. And this is a disease also that is not so uncommon, about 74,000 patients and about 15,000 deaths. And risk factors include smoking, hypertension, obesity, acquired polycystic kidney disease, and also occupational exposure. Renal cell carcinoma comes in different flavors. The most common histological type is clear cell, and about 75% of cases. Then second most common is papillary, that could be type 1 or 2, and less common are other types like translocation RCC, collecting duct, or medullary. The treatment for advanced renal cell carcinoma is also multidisciplinary, and sometimes it may involve surgery like metastatectomy or cytoreduction in selected cases, but most of the patients with metastatic disease at some point will require systemic therapy. this is kind of like a historical tour of all the approvals of the different agents. And it is interesting, like there's a lot of drugs, but basically you can just focus on the trends here. Initially, like when I finished fellowship, when I was junior faculty at Mayo Clinic, I participated in the pivotal sunitinib study. That was my first study ever that I participated. And we enrolled significantly, and that showed that sunitinib was effective and led to approval in 2006. And as you can see, from 2005 to 2013, the field was kind of like dominated by targeted agents, mostly anti-angiogenic agents or mTOR inhibitors. So, and mostly were single agents, except for the combination of bevacizumab and interferon. So until about 2015, we treated patients with either anti-angiogenic agents or mTOR inhibitors. After 2015 came the immunotherapy wave, okay? And the first agent approved was nivolumab, okay? Cabozantinib, another targeted agent, was approved, and lenvatinib and everolimus as well. But then we continued with immunotherapy. So in 2018, we started immunotherapy combinations, but only immunotherapy agents alone. And what I'm going to talk today very quickly will be on the new trends in the management of advanced first-line kidney cancer, which is combinations of immunotherapies plus anti-angiogenic therapies. So the combination, what we call IO for immunotherapy agents or immuno-oncology agents / TKI, is the new standard of care in the majority of patients with kidney cancer. In general, combination therapies, either with TKIs, immunotherapies, or immunotherapy combination like ipilimumab and nivolumab, are the new standard of care. And this is just a review of two studies that have been published. One, axitinib and pembrolizumab versus sunitinib as a control, axitinib and avelumab versus sunitinib, and more recently, cabozantinib, a newer generation TKI, and nivolumab, an anti-PD-1 agent, versus sunitinib. And all the three studies showed very similar results. Response rates were very high. As you can see, 59.3% in one study, 51.4%, 55%. So above 50%, which is incredible in kidney cancer metastatic. Progression-free survival was also significantly better compared to sunitinib, like 15 months versus 11, 13 versus 7, 16 versus 8. And that translated into protection or a very, very significant hazard ratio of 0.69, 0.69, and 0.51. So the first two studies were published and were presented last year, and that led to FDA approvals back-to-back in April 2019 for the combination of axitinib and pembrolizumab, and also in May of 2019, axitinib and avelumab. The cabozantinib and nivolumab is not approved yet, but the expectation is that it will get approved soon, probably later this year or early next year. However, again, just for the record, cabozantinib and nivolumab is still considered an experimental option, okay? Now, to finish, there are two novel targets that are very exciting. One is a drug that targets hypoxia-inducible factor 2 alpha or HIF2 alpha, a drug called MK-6482, which we are also helping develop and participating in most of the trials, and has induced improvements in terms of response rates in patients who have been heavily pretreated. So this may be a drug of the future in the next couple of years. And also targeting tumor metabolism with a drug called CB839 that has been given in combination with cabozantinib that targets glutaminase in the tumor. So the field of kidney cancer research is very, very promising. It's great. It's a good area to be and to do research on, and the patients are benefiting significantly. So this is my last slide as the conclusions. Okay, you can see that research, clinical research and basic research have led to a lot of new agents and a lot of new drugs. We have a large menu and portfolio of agents that we can choose from. And the biggest challenges right now is to find the best drug for each patient based on the clinical risk, based on the patient's performance status, on the comorbidities, on the size of disease, etc. So the new trials that we're doing are trying to answer now those questions, how to personalize, individualize so many treatment options we have in patients with kidney cancer, and what newer drugs can we bring in order to further increase response rates and hopefully cures. And as I always say, enrollment into clinical trials is highly encouraged, and that is usually our standard of care at Sylvester. All of our patients we enroll into clinical trials. So with this, I will finish, and thank you very much.
Thank you very much for that excellent presentation, Dr. Merchan. I was wondering, we have exactly 2 minutes for the next speaker. I wonder if there are no other questions, maybe I could comment on, ask you to comment on the social determinants of disease that are related to renal cell cancer. In other words, do we find certain racial or ethnic groups are more responsive to certain biologicals than others, or is there just not yet enough data available?
That's a great question, Dr. Weiss. There is no data yet available. There seems to be some research being done to determine whether responses to immunotherapy agents in cancer and in cancer in general can be differentiated or determined by the biological sex. There are preclinical studies that may show that females versus males may respond differently to immunotherapies. And like in my lab, we're doing some of that. And we see, at least in preclinical studies, that in some models, male mice respond better to immunotherapy, and female mice respond better to other types of immunotherapy. Socially, in terms of race, ethnicity, there's no clear indication yet that there are differences. We are also are creating a big database. We have a large Hispanic population, and with one of our fellows, Dr. Trisha Plastini, we are trying to look into differences in response or difference in toxicity among different ethnicities.
Thank you. And lastly, Dr. Lakakis, do you want to unmute yourself and ask your question?
For locally advanced bladder cancer, if the patient is not eligible for cystectomy and goes for cisplatin chemoradiation, is there any role of consolidation with PD-1 inhibitors?
Yeah, so basically, patients who, well, first, like at we would put the patient in one of our trials. We have a trial of enfortumab vedotin exactly for those patients, right? And we're doing that alone or in combination with pembrolizumab, and we have, and prior reports show a very high response rate in those patients, even complete responses. So, but basically, as a standard of care, if patients are not a candidate or refuse a cystectomy and are not candidates for cisplatin, some of the standard options would include...
So if they are candidates and they go for cisplatin chemoradiation, is there any role for consolidation, PD-1 or PD-L1?
Yeah, there's no evidence at this time. Okay, there are trials that we're doing, giving a pembro in the adjuvant setting. After cisplatin and after surgery, we are randomizing patients to either immunotherapy or observation.
Thank you, Dr. Merchan. There's also another, I'm sorry to cut you off, there's also another question by Dr. Singhal in the chat. If you have a chance to look at it, perhaps you can contact him directly and answer his question. But we do need to move on because we have 2 speakers today. That was enlightening and very well presented. Thank you, Dr. Merchan. Dr. Luna, could you introduce Dr.
Yes, sure. Okay, so we have the honor to have Dr. Binu John. He is currently Assistant Chief of Medicine and the Chief of Hepatology at the Miami VA Medical Center. He completed medical school at the Christian Medical College in Vellore, India, and internal medicine residency, GI, and transplant hepatology fellowships at the Cleveland Clinic in Ohio. Prior to joining to his current position, Dr. John was Associate Professor of Medicine at Virginia Commonwealth University and the Medical Director of Liver Transplantation at the Richmond VA Liver Transplant Center. His areas of research interest include hepatocellular carcinoma, health outcomes in chronic liver disease. He has served on the Practice Guidelines and Journal Publications Committee for the American Association of Study Liver Diseases and Clinical Research Committees for the American College of Gastroenterology. Dr. John has over 50 peer-reviewed publications and over 100 abstracts, and his research has been funded by the National Cancer Institute, the Patient Centered Outcome Research Institute, and the American College of Gastroenterology. His topic today is titled A C-eismic Shift from Hepatitis C to Fatty Liver, Updates in Hepatology. Welcome, Dr. John.
Thank you, Dr. Luna. Thank you, Dr. Weiss and Dr. Paul Martin for the opportunity to present. I'm going to discuss updates in hepatology. And so I titled this Seismic Shift from Hepatitis C to Fatty Liver, because we are seeing a shift in epidemiology. And so over the next 20 to 25 minutes, I'll talk about what's new in hepatology across these fields. So I have no disclosures relevant to this talk. So the three updates I'm going to talk about in the next few minutes, I'm going to describe the change in epidemiology from chronic hepatitis C to alcohol-associated and non-alcoholic fatty liver disease. We're going to talk about new changes in alcohol-associated hepatitis and the upcoming role of liver transplantation in these patients. And then we will discuss non-alcoholic fatty liver disease, which is the growing epidemic and now the commonest cause of liver disease in the world. And we'll focus on non-invasive methods to assess this. So 2020 was not a great year for most of us, but for hepatologists, there was a silver lining. So last month, the Nobel Prize for Medicine and Physiology was awarded to these three scientists. All three of them did their work in the United States and shared the Nobel Prize for the discovery of the hepatitis C virus in 1990. And in just 30 years, we now have treatments. From the time this virus was discovered till today, we now have treatment options that can cure almost every patient with hepatitis C who has access to these medications. And because of this, there's a massive change in the epidemiology of liver disease. So this is a graph that was unimaginable 5 years ago. This is a study that was published this year. On your y-axis here is cure rates, or what we call SVR12 rates. And on your x-axis are the genotypes of hepatitis C. And you can see whether it's the dark blue bars on a per protocol basis or the light blue bars on an intention to treat analysis, that our ability to cure hepatitis C is virtually 99 to 100% in patients who take the medications. And on an intention to treat, it's still about 97 to 98% with first-line agents with just 8 weeks of treatment. And this is common across multiple agents. So this is a different study with a different agent. Again, this is a combination of sofosbuvir, velpatasvir for 12 weeks, and you see the same data. Across genotypes, we are talking about a 98 to 100% cure in hepatitis C. And what this is resulting in is a very significant change in disease epidemiology, both of hepatocellular carcinoma, which occurs primarily in patients with liver disease, as well as patients with cirrhosis. On your y-axis is the number of deaths per 100,000 in the population, and the graph on top is really deaths from hepatocellular carcinoma. The blue graph on top is hepatitis C, which is the commonest cause of liver cancer deaths. But as you can see that it's flattening. And what's going up is the red bar, which is non-alcoholic fatty liver disease, and with alcohol and hepatitis B on top, saying about the same. What you see on the graph below is actually deaths from cirrhosis. And on top, on that red bar is again, non-alcoholic fatty liver disease. which is the commonest cause of cirrhosis death in the world now, and is not showing any signs of flattening. But what you see going down is the bar in black, which is hepatitis C. And this coincides with the treatment that have come out since 2013 and 2014. So we are seeing the shift move from hepatitis C to fatty liver disease, both from alcohol and non-alcoholic fatty liver disease. So then let's talk a little bit, and this again is the worst, the most severe patients on the transplant wait list. You see on the blue bar on top is non-alcoholic fatty liver disease, which has been flat from 2006 to 14 and now going up, is now that with alcohol are the commonest cause of cirrhosis, patients with cirrhosis on the transplant wait list. And what you see on the dark green bar is hepatitis C, which used to be the commonest, but is now dipping. What's also interesting is the red bar there with hepatocellular carcinoma. We are seeing more patients with HCC on the transplant wait list, whereas cholestatic liver disease and alcohol remain flat. So in addition to this significant change in epidemiology, we are now seeing a lot more of alcohol and non-alcoholic fatty liver disease. So let's see what's new with alcohol-associated liver disease. I think one key thing is the change in terminology. So the times they are changing, and many of the terms we used in the past are stigmatizing to patients, and those are move for change in terminology in our field as well. So we no longer call patients who use alcohol alcoholics. We no longer use the term alcoholic hepatitis. It's called alcohol-associated hepatitis and alcohol-associated cirrhosis. Instead of alcohol abuse, we call it alcohol use disorder. So in addition to the change in terminology, what a significant change in the field is increasing use of liver transplantation for alcohol-associated hepatitis. Now, this is the spectrum of alcohol-associated liver disease. And you can see in patients who drink alcohol, many of them develop steatosis, which is fatty liver, which is on your second graph picture there. And about 20 to 40% of these patients go on to develop fibrosis of the liver. And fibrosis is deposition of the scar tissue in the liver, which can progress from a stage 1 to stage 4, which is also called cirrhosis. And then once you have cirrhosis, patients with cirrhosis can develop hepatocellular carcinoma, which occurs approximately 2 to 3% a year in patients with alcohol-associated cirrhosis. Now, the risk factors for this progression, it depends on the amount of alcohol. It also depends on obesity, but also genetic factors. So there are 2 people who drink the same amount. We have identified certain genes, for example, the PNPLA3 mutations, which can predispose patients to develop advanced liver disease compared to patients who lack the mutation. And so this variation is more common in Hispanic patients and Caucasians compared to African Americans. What else affects the progression of cirrhosis and fibrosis is actually coffee. So across multiple epidemiological studies, we have found that patients who drink 2 to 3 cups of coffee have about a 20 to 25% decrease in progression of fibrosis compared to patients who do not. And interestingly, this association has been seen both with caffeinated and decaf coffee, suggesting that it's really not the caffeine, but potentially some antioxidants that might predispose to this relationship. In any case, the most profound and severe form of alcohol-associated liver disease is called alcohol-associated hepatitis. And this is a condition where patients present with coagulopathy, jaundice, possibly renal failure in the setting of active alcohol use, and is characterized by severe inflammation of the liver. This condition is associated with between a 15 to a 20% 28-day and a 30 to 35% 90-day mortality. So it's a very, very high, a condition with a high mortality. And so one of the issues with these patients, we do know that if they remain abstinent, they get better. But the issue is if 40% of your patients die in 6 months, many of them don't have the time to remain abstinent and get better. And in the past, there were concerns about these patients and offering liver transplant to these patients because there was a concern they would drink alcohol after their transplant. There were concerns whether they would be adherent to the medical regimen. And there was a perception that alcohol use is self-inflicted and what the public would think if we transplant patients who drink alcohol. And because of all of this, we had what we call the 6-month abstinence rule, where any patient with severe or any amount of alcohol-associated liver disease would have to demonstrate a 6-month period of alcohol abstinence before they undergo a liver transplant. And like we discussed, unfortunately, 40% of these patients are not alive in 6 months. And so a lot of young people who potentially never knew about the amount of damage that alcohol caused their liver now no longer have that opportunity for a life-saving procedure. And so the pros of waiting 6 months was the time you give spontaneous liver recovery, and you can also monitor these patients for relapse. But the downside was the high mortality in these patients. And so there was this study that was published in the New England Journal of Medicine by a French-Belgian group. And what they did was they said that of all patients with alcohol-associated hepatitis who come to the hospital, they had a screening protocol where they selected the patients who they felt were most likely to do well. And these included psychosocial factors like having a close supportive family, no prior treatments, failed alcohol treatment programs, and a complete consensus among the treatment team that they thought that the patient had good prognostic factors, that they would do well after liver transplant, and also in terms of alcohol relapse. And so they screened over 200 patients, and only a small proportion of these patients, actually they screened over 2,000 patients, and only a small proportion of these patients qualified for the trial. But what they found was that among the patients who underwent that liver transplant, they found very, very good survival rates. So these rates of 75% at 4 to 5 years were comparable to liver transplant survival for other conditions that we transplant patients for, and compared to case controls who had a 35% survival at that same time period. So this paper opened up the possibility that carefully selected patients with alcohol-associated liver disease might do well, and that it did take some time for it to be taken up in the U.S. But this was a paper that was published a couple years ago by a consortium of 12 centers across the United States, which showed that 147% patients transplanted had 94% survival at 1 year and 84% survival at 3 years, and that the sustained alcohol use after transplantation was relatively low. And these patients on an overall, they did well. And so this has led to a change in our field where more and more centers, transplant centers in the United States are transplanting patients with alcohol-associated liver disease. You know, back in 2014, there were about 10 centers, and in 2017, there are 50, and I would say right now, this number would potentially be double or what it was in 2017. And so now there's widespread uptake. Obviously, there are criteria differences from center to center. Some centers are very aggressive and some centers are very conservative. But the fact that patients with alcohol-associated liver disease had to wait 6 months for transplantation is no longer a dogma in our field. And so a summary of that second highlight is that liver transplant may be considered for highly selected patients with severe alcohol-associated hepatitis. And the key is patient selection of patients who have good prognostic factors, including good social support, absence of psychosocial barriers, and no history of prior relapse after substance abuse treatment. The last update I'd like to talk about is the biggest, most commonest disease we are finding in our field, the epidemic of non-alcoholic fatty liver disease. So this is a chart that shows you the prevalence of non-alcoholic fatty liver disease in the world. And this is a paper that from gastroenterology by Mike Charlton and colleagues. Compares the energy available, so the abundance of food and the correlation with non-alcoholic fatty liver disease in these countries. And as you can see here, the prevalence varies from as low as 13.5% in sub-Saharan Africa to as high as 30 to 31% in parts of South America and the Middle East. And the United States, though, is the most energy-dense country in the world, but it's not necessarily the highest prevalence compared to some other countries, suggesting that genetic factors might also play a role in this condition. And with non-alcoholic fatty liver disease is a spectrum varying from patients with simple steatosis on your left, which is essentially fat globules in the liver without inflammation, that can progress to inflammation in the middle screen. The big arrow there you see is hepatocyte ballooning, and then those eosinophilic particles you see in those cells are Mallory bodies, all suggestive, and then inflammatory cells, all suggestive of NASH, or non-alcoholic steatohepatitis, which in these patients can progress on to develop steatofibrosis, where the liver injury from NASH is associated with scar tissue and can progress to cirrhosis. And fibrosis in the liver is the strongest predictor of clinical outcomes. And the gold standard of assessing fibrosis is the liver biopsy. But unfortunately, not all patients can undergo a biopsy because this is invasive and is associated with the risk of complications and sampling error. And therefore, we now have non-invasive assessment tools to assess non-alcoholic fatty liver disease. These include blood-based tests and imaging-based tests. The blood-based tests, I'd like to highlight Fibrosis 4 score, or the FIB-4 score, and the NAFLD fibrosis score, and then imaging-based techniques, which include a Fibroscan or an elastography and an MR elastography. The FIB-4 score is something that you can easily calculate on your phones or on your computer in your clinic. It includes really age, AST, platelet count, and ALT. And so once you plug in these numbers, you get a score which can vary from as low as 0 to as high, it can go up. And you have two cutoffs. The FIB-4 score of less than 1.3 is highly sensitive and has got a high negative predictive value to rule out advanced fibrosis. A FIB-4 score of greater than 2.67 has a high positive predictive value for advanced fibrosis. And so in patients with fatty liver disease in your clinic, you can do a FIB-4 score and assess if these patients need further evaluation. A similar score is the non-alcoholic fatty liver disease fibrosis score. Again, the NAFLD fibrosis score available online. It takes into account age, BMI, AST, ALT, platelets, and albumin. And a score, again, if your score is less than the certain cutoff here, your likelihood of advanced fibrosis is low. If it's greater than 0.675, your likelihood of advanced fibrosis is high. And so these are ways you can triage patients at risk, patients with fatty liver at risk for complications, into a hepatologist's office. And what do we do in our offices? We often do a Fibroscan, which essentially is a way to use sound waves to measure the stiffness of the liver. If you have a stiff liver from advanced fibrosis, it dampens the flow of these sound waves. And so the velocities are affected and your liver shows as highly stiff. And so there's a great correlation between the degree of fibrosis on a liver biopsy and the amount of stiffness. And similarly, we also have MR elastography that can compute the same thing. So when you look at the correlation between a Fibroscan and an MR elastography, you find that a cutoff of 6.2 or less is fairly good to rule out patients with advanced liver disease.
Yeah, I'm texting Teresova to see if she wants to see him.
And patients with a fibrosis score of greater than 9.8 or 16 is highly sensitive to pick up specific to pick up patients with advanced fibrosis. So how, as a physician or a general internist or a hospitalist or a primary care doctor in your clinic who is seeing a patient with possible non-alcoholic fatty liver disease, how do you approach these patients? So one, if you have a chronic AST or an ALT elevation greater than 6 months, or evidence of steatosis on any imaging, or if you have a patient with type 2 diabetes with one other metabolic syndrome and elevated liver enzymes, or if you're a non-diabetic with 3 or more metabolic syndrome components. A simple test to do in your clinic is a FIB-4 score and a NAFLD fibrosis score. Really, all you need is a hepatic function panel and basic labs that are available for all patients. And if your FIB-4 score is less than 1.3 and a NAFLD fibrosis score is low, those are patients who can be followed up with a primary care doctor and advised lifestyle modification. On the other hand, if your FIB-4 score is higher than 1.3 or your NAFLD fibrosis score is high, those are patients who need to be evaluated by a hepatologist and undergo a transient elastography or an MR elastography. And if that's abnormal, oftentimes we do a liver biopsy and refer these patients for clinical trials. So in summary, the field of hepatology is changing. And so we are seeing a shift from hepatitis C to metabolic associated and alcohol associated fatty liver disease. We are now flattening the curve of hepatitis C associated cirrhosis and hepatocellular carcinoma. We spoke about the new terminologies with alcohol associated liver disease, including alcohol associated hepatitis and cirrhosis. And we discussed how liver transplantation is now being considered in patients with alcohol associated liver disease in highly selected patients, even without the 6-month abstinence rule. We gave an overview about non-alcoholic fatty liver disease, including a worldwide prevalence of 15 to 30%, and how primary care physicians can, or non-hepatologists, can use the combination of non-invasive tests like FIB-4 score and a NAFLD fibrosis score in combination with elastography to identify patients at increased risk of outcomes. Thank you.
Thank you, Dr. John. That was an excellent presentation, very clear and relevant. We have, let's see, some comments in the chat. Dr. Martin, do you have a question?
Sure. So, Binu, great talk. Can I ask you, what advice do you give to patients who've unequivocal non-alcoholic fatty liver, but who consume only, even by our standards, a moderate amount of alcohol? Do you prohibit it completely, or can they drink once in a while?
So that's a great question, Dr. Martin. There was a time when there was some early research showing that
Please mute yourself if you're not talking.
There was a time when patients with non-alcoholic fatty liver disease, there was some data to show that modest amounts of wine was protective in these patients, but that was some early data. Now, I would say with most patients with non-alcoholic fatty liver disease who have NASH or who have any amount of fibrosis, I advise these patients not to drink any alcohol. So they already have proven that they have risk at progressive liver disease. And so the combination of these risk factors can worsen the progression of fibrosis. So patients with NASH and any amount of fibrosis, I advise them not to drink alcohol. I also advise them to drink 2 to 3 cups of coffee every day. And most of my patients love that.
Dr. Lakakis, would you like to ask your question? Unmute yourself.
Yeah, in the treatment, pharmacologic treatment of non-alcoholic steatohepatitis, any role of thiazolidinediones and or profibrotic inhibiting profibrotic substances like TGF-beta or PDGF or FGF?
Yeah, so that's a great question. So with thiazolidine-diones, there was an NIH-sponsored study looking at pioglitazone and vitamin E in non-alcoholic fatty liver disease. And the downside with that was weight gain, and they found that the trial with the pioglitazone was negative. The trial with vitamin E was positive, and there was a time when we gave non-diabetics vitamin E, but there are now concerns about long-term vitamin E in patients, about risk of prostate cancer and cardiovascular, and so we no longer do that. There are many antifibrotic agents in the pipeline that are being tested, a number of clinical trials. There are many anti-diabetic medications that have been, including GLP-1 agonists. A lot of these drugs that we use for diabetes are now undergoing phase 3 clinical trials in non-alcoholic fatty liver disease. There's only been one positive clinical trial. That's a drug called obeticholic acid. And that, unfortunately, it's not been FDA approved because there are many concerns that it increases LDL cholesterol. It is associated with significant side effects like pruritus. And so that's a drug that it's not FDA approved, but that could be something that might be FDA approved down the road. We have 2 or 3 other promising agents that likely will be approved in 2021.
Thank you.
Well, I want to thank both our speakers today for excellent grand rounds, and would remind everybody to fill out their CME and MOC at the end of today, and wish everyone well, and we'll see you next week. Have a great day and be safe.